prevention programs at ICWA. And today we're very lucky to have Felicity come along and talk about the development of a falls framework for Bethanie residential aged care, which she actually presented in Brisbane only a few weeks ago at the Falls conference, so it's great for her to come along. So I'll just quickly talk about Stay on Your Feet if no one's heard of us before. We're funded by the Department of Health, and we target people over the age of 60 and people over the age of 45 for Aboriginal and Torres Strait Islanders. We aim to improve the knowledge, attitudes and beliefs among seniors that falls are preventable, reduce the incidence of falls and reduce the severity of falls-related injuries. And I just thought I'd remind everyone of the 9 steps to Stay on Your Feet if you've never heard of them before. We have heaps of resources, pamphlets, info that we can give your clients that you may be interested in. We can talk about that a bit later. But I'll move away from the camera now and let Felicity have a chat, and I think we'll try and leave mainly questions to the end, but maybe we'll, you can ask questions if you really need to. But here's Felicity.
Thank you. Well, welcome everybody here and remotely. I guess what I'm here to do is far less formal, I hope, than what I was doing in Brisbane. To give you a little bit of background, for me, I'm an occupational therapist and I've been working in aged care for about 2.5 years now. Prior to that, I was in acute care. And I guess what I found when I transitioned from acute care into residential aged care particularly, although the Bethanie group goes across residential and community, was that there perhaps hadn't been the same opportunities to invest in systems and processes. So although I'll be, I guess, touching on what's best practice, a lot of what I will be focusing on today is the systems and the processes that we put into place to develop our falls framework.
No? Oh, my left. Yep. Yep. Okay, beautiful.
I am going to get the hang of it, I promise.
Yep.
Okay. So I'll look at what were the drivers for change within the Bethanie group, the why factor in terms of putting this together. What were some of the challenges, and I think I was struck by the difference within the aged care sector as opposed to acute care with some of the challenges that we faced. Our process, an overview of what our falls framework looks like, and then what are some of the specific elements of it. Obviously the framework itself is fairly big, but I'll need to look at what are some of just the key elements within that. If you don't know Bethanie, we are a community and residential aged care provider. For the benefit of people from Brisbane, I kind of just did a bit of a circle on the map. So we've got community programs running between Geraldton and Bunbury, and we've got residential aged care between Yanchep and Bunbury. So we're looking at around about 1,000 beds for residential is really the focus of this program. I'm probably preaching to the converted, but the reality is that residential aged care is a significant factor of the people that we care for, is the fact that they fall, and they fall regularly. So you're looking at a couple of falls a year for most people, although there is that standard bell curve where you'll have people who come in quite mobile and more likely to, less likely to fall. During that window in the middle, we've got an increase in their falls risk, and then as people decline functionally, we'll see less falls happening. Most of the falls, 75%, you're looking at bathrooms or bedrooms, and again we know that they're also the high-risk areas for injury associated with falls at that time. 41% during transfers and 36% while people are walking. We also know that within residential aged care there's significantly increased risk over community. So we think about our community fallers as being frequent, but it's much more likely to be happening within the residential aged care environment. There's also some assumptions made, and I'm not sure for all of you whether aged care is the sector that you come from, but I can honestly say that within the acute care environment, when I was working in acute care, there were some assumptions I made around the supports available in residential aged care to manage falls. So we would get to a point where you certainly provide some input acutely, but you'd assume the physio, the OT and the support workers could provide a lot of support upon return to the residential aged care environment. I think particularly with security of tenure, we see the turnaround in the acute sector being much, much quicker, and so post-fall people are returned to their facilities. But the reality is really that although the acuity of residents within the aged care sector has increased over time, there hasn't been a subsequent increase in the support staff available to deal with those residents. So there's still a mismatch between what the needs of our residents are and the number of staff and the training of staff available to deal with those. The staff that we have in situ within residential aged care come to the industry with the hugest hearts you're going to find on the face of the planet. People work in aged care because they care about the people that they're working with. But for a lot of them, their background is incredibly diverse. So with that diversity can also come diversity in educational background, in management of language, and all of the other things that we know comes with that diversity of workforce. And that in itself, I think, presents a challenge for any sort of system or process within the residential aged care environment. We also know that in terms of their background, they've been here for less than 5 years, but we've also got only 15% of new employees to the aged care workforce from a CAL background having had any healthcare experience. And often you will find people might be highly educated in their country of origin, but for some reason aren't able to work in their chosen industry here, and aged care seems to be somewhere that people will end up working. So backgrounds in sales, hospitality, cleaning, clerical work, not necessarily care, just adds to the challenge, I think, of supporting our workforce with falls prevention. 66% hold a Cert 3 in aged care, and that's certainly something that we continue to see increasing, but there's still a third of that workforce who may not have that basic level of training that would help with falls prevention. We see a 50% turnover in care workers every 5 years. So we've got not only a workforce that's a challenge to educate, but also a workforce that turns over regularly. So again, when I was thinking about systems and processes, it was really important that whatever we put together was something that could be very easily taught, could be managed by people within a short period of their arriving with us as an organisation. The funding ratios for aged care. The ACFI instrument is something that most of us in the room, if you've worked in aged care, are fairly familiar with, but the nature of it means that that's often what will drive the care that's provided, and will change the nature of the way that people engage with education programs, or with organisations, the way that they engage with education programs and other things that are out there. So we needed to make sure that whatever we did really did tie with the funding instrument and with the Aged Care Standards and Accreditation Agency. And I was saying to Emily earlier, I think one of the big challenges within the residential aged care environment is to have things supported by the accreditation agency, because that is still what drives what we do within the residential aged care environment. So in terms of ACFI, what we saw was that we are seeing a steady increase in the needs of the clients that we care for. So I mentioned acuity before. So certainly the nature of the patients that we look after are becoming increasingly complex, and I would almost describe the aged care sector now as a different subacute environment. In our heart of hearts, we know it's people's homes and we want to make it as home-like as it can be, but the nature of the illnesses and the chronic conditions that we're managing, and then the acute care discharges that come back very quickly, means that the workforce needs to be able to respond to both that subacute need and also the home-like environment, and that's a tough ask. So I think that's the challenge for us within the aged care sector. So there's the morbidity and falls within the residential aged care sector. So we know that lots of our residents are falling. We also know that that has a direct correlation with significant injury for them and for poor outcomes in terms of their lifespan. There's the financial cost of falls. So both the acute care cost, and this again is something that Emily and I speak about quite often, is that although Commonwealth funding is responsible for the aged care environment, state government are the ones who are funding the results of falls. So when we have falls in the aged care sector, they're still presenting for emergency departments, they're still requiring that acute care intervention to care for the individual. So in summary, there's lots of challenges, and I guess that's why, for me, this idea of having a falls framework is a very necessary one, but I also think it's one that we are all busy trying to invent our own wheels. And that's something that worries me, and I'll talk about that a little bit more later on. So in summary though, we've got our support staff challenges, the limited hours that our support staff have, and again, I guess with the support staff, a lot of things have become task oriented. Support staff come in with those big hearts, but they've still got a list like this to get through every day. So it becomes about who needs a shower, who needs a feed, who needs this, who needs that. And we've got to shift that, and person-centred care gives us the vehicle to do that. But at the end of the day, there's still all those jobs that need to be done. So that's another balance. The funding, the implementation of policy, and the increasing acuity of our residents. So lots of things that complicate the systems around falls prevention. So I started with Bethanie at the end of 2010, and within a few months became involved with the falls group. And the situation as it was then was that there was the clinical governance team, and there was an overview of falls, so there certainly was a system in place. There had been a falls prevention management review completed, but not implemented at this stage. So, like so many things, we took the time to look at it, but we were still, the wheels are spinning a little bit, and we're still finding a way to look at implementation. We have, or had, a falls group that met 6 monthly. There was no physio on that group, and I guess that probably reflected the fact that our physios historically were employed by the site and managed by the site. With me coming on board, we collected that together and were able to, I think, have more impact from an organisational perspective because we had the numbers to be able to look at how physio could support things differently. We did have, with the benefit of a really good IT department, an embedded CRI system. So when there was an incident, it did go into our electronic medical record and it was acknowledged and there was some action. But again, there were things that were not working as effectively as perhaps they could with that. We used QPS benchmarking, so we knew that we weren't doing very well in terms of falls prevention. And I'll talk a little bit more about benchmarking and some of my concerns around that later.
Excuse me, Felicity, sorry.
Yeah.
I don't know what the acronyms mean. I don't have them from
Sorry?
care at the moment.
So CRI is care recipient incident. So rather than patient, often aged care will use care recipient. And so that was if there was a fall, that there would be a system whereby that was noted and entered into our stats systems to tell us how many numbers we had. QPS is an organisation and they do benchmarking nationally, so we're able to track our falls rates as opposed to similar organisations and internally benchmark how many falls we've got per site.
And SQL?
SQL query. A systems, I'll have to come back to you with the numbers. It's a technical term within the electronic medical record where we can, it's a systems query, where we take the data that we have, pull it out and see what's going on in there. Yeah. So it's running a report essentially from iCare. We did have our local systems working together, but again without that overarching comprehensiveness that was going from the team all knowing what was happening at other sites. We had a FRAT completed with every resident after every fall. And I don't think we were unusual in doing that. I think a lot of systems have required that FRATs are done regularly, and by regularly, we've taken every fall to be that benchmark. Falls risk assessment tool, and I'll be going through that as we go through. The falls management guidelines, again a tool that we will talk about today. The best practice guidelines were embedded in policy, so they're in a file. In our case, it was a computer file or a hard copy printout of that file. And I don't know about you guys, but for us, if a file's sitting on a shelf or in a computer somewhere, that's pretty much as often as it gets opened is when somebody goes through the rigmarole of trying to find where it is. So it was sitting in policy and we had some really good practices in there, but there's a big gap between policy and practice, in the same way as there's a big gap between evidence and practice. I heard at the conference that I presented at in Brisbane that the acute care gap between research and it being integrated into practice is 17 years. I would challenge that if it's it's 17 years in acute care, it's probably 34 in aged care. And that's not through any fault of the people working in aged care, it's just that it takes longer for those things to go through the system. Post-fall assessment. So we required our staff to, when somebody had a fall, you assess them. You do post-falls obs, you do all these things. But really we left that to the clinical judgment of the person post the fall, and they would then document that in the progress notes. And what we found was that there was a big diversity between the way one person did a post-fall assessment and the next person. So that was another issue that we had going on. So we knew there were problems. We knew also that there were things like this, beautiful guidelines around the prevention of falls and harm from falls in older people. And these are the best practice guidelines for Australian residential aged care facilities 2009. So this is current best practice. But you know what? People don't look at this stuff. We know it's there. We're grateful for the fact that somebody has pulled it all together. But in terms of taking that and integrating it into practice, we really hadn't gone down the line of embedding it. And I don't think we're, again, often in that. So the process, as I said, I was involved from May. So I'd taken a few months after starting to understand the aged care sector a little bit better. And then had come in May to the Falls Focus Group. So TSM, Therapy Services Manager, so that's the role that I played within the Bethanie group. We redefined the terms of reference. You always have to do that when you get involved. I don't know, I'm not a great theorist, and I think it's about the practical implication and the way that we integrate these things. So again, terms of reference really just go in the front of the file and you know that they're there. We included a physio in the Falls Focus Group, so that was the first gap, I guess, that I recognised, and we had one of the people that I perceived to be a high-performing physio involved in that group. Stay on Your Feet Week, we got involved with Emily and the crew at ICLA and had our first rollout of programs for Stay on Your Feet Week in September of 2011. Again, a great opportunity to raise the profile of falls, but not really something that was going to make a lot of difference unless we got our staff understanding up to par. In February of 2012, time just slips away, I just realised that this was above and beyond me, that this was an organisational issue and something that unless I had lots of key players on board was never going to happen. So the key players for us were myself as the coordinator, Jenna Athens, one of our lead physios in the organisation, the clinical governance manager, who's also got an RN background, another clinical governance support person, and really importantly for us, because we use iCare, the electronic medical record, so we are paperless for all intents and purposes, we needed someone with that IT background to help us do what we needed to do in order to put things in place with the system. The things that we missed, and I think they're as important learnings in these kind of forums as anything else, we needed to have a site manager on board. We continued to have interface with them, but we didn't have anyone at the table when we're saying, hey, what about this and what about that? And just as importantly, we should have had a carer representative, because it's all very well for us to come at things from an overarching level, but if you're not working on the floor every day, as much as you might have experience, you lose sight of what it is that's actually going to be doable. So we've remedied those things to some extent, but I still think we can improve it. I think, and in a lot of organisations, we forget to get that grassroots representation to really make sure that the systems we're designing are going to be the ones that are actually going to work. So what we did look at reviewing best practice, so that needed to happen. And we looked at a revision of the Falls framework. So we did have a framework in place, and I'll talk to you a little bit more about what the new one looks like. But again, it was really just about how long had this thing been sitting there, and when did we look at it last? Partway through this whole process, this beautiful document came out. So the Cochrane collaboration. So most of you will be very familiar with Cochrane reviews. They take all of the evidence that's out there and they review the evidence so that we know that we are responding to the right things. And I think this has been another real learning curve for me throughout the process, was that in aged care, I think we tend to respond to people who have really good ideas and they're passionate about it, but we don't always ask the question around what's the evidence for it. Sounds like a great idea, fantastic, let's do it, is what we're very good at. But I think we need to back up a little bit. Say, okay, well, what's the evidence around that? Is there any indication it's going to make a difference? And if so, yes, let's do it. If not, is there something we could get better effect out of? And I think it will become clear as I go through why I say that. There's lots of evidence out there. There's not a lot of robust evidence. There's not a lot of depth to the evidence around the prevention of falls in residential aged care, and that's the unfortunate reality. There's a few things that we know will make a difference, and I'll talk about those as we go through, but just the key things, vitamin D supplementation. Vitamin D supplementation is only good though if you're actually doing bloods to make sure that you're at therapeutic levels. There's a lot of people that kind of go, oh, we'll put them on vitamin D, but do we ever check back and see whether that's an issue? Exercise programs, yes, there's some efficacy, but they must involve balance and stability exercises. Without that, walking programs do not make a difference to falls prevention. Are they great? Yeah. Should we still be doing them? Yes, because they have all sorts of other benefits. But if you are purely looking at falls prevention, a walking program shouldn't be the one thing that we have on our list of things to do. And I think they're the sorts of things that we do see integrated into aged care, and we put those things up as our strategy for dealing with falls. But again, I think we need to ask ourselves the question about whether they're the right things to be putting in. So I'll go through some of those things just so that we can identify some of the benefits. So from Cochrane, there was no evidence of reduced falls from exercise. It did increase the risk of falls in high care. With most of aged care now, low care is almost a thing of the past. There's very few facilities that are purely low care. So we need to be very careful around that. Intermediate care, there is a benefit for. So for those people who are still mobile, so long as it's got that stability and balance integrated into it, definitely a good thing. Vitamin D, talk about that. Staff training, no reduction in the risk of falls, according to this. And we spend millions of dollars every year on staff training. Now, does it mean we shouldn't do it? No. It means we should integrate it with other things. It can't be a standalone strategy that is going to make a difference. Service model change, very sadly, not a really big difference, which was very sad to discover partway through a service model change. There was some indication that if you were using a falls risk assessment tool versus just nurses' judgment alone, that there may have been some benefit. And interestingly, dementia mapping, which is something very new to aged care in Western Australia, was seen to be more effective than person-centred care on its own. Again, different strategies that are worth looking at. But if you had a practice nurse to support you in the adoption of things, that could be helpful. One of the things that Stay on Your Feet program has told us for a long time is that we need more than one line of defence. So multifactorial interventions based around the needs of the individual. So not just we do everything for everybody, but we assess the individual and then use more than one line of defence to manage their falls, definitely seen to be more effective. Nick and Anne-Marie Hill, so Nick Waldron, for those who don't know him, have done loads of research obviously around falls, and there's been some, I guess, more opportunity to see that out in the wider media. So certainly we've got some gold bar standards now for residential aged care, but again, it's really only vitamin D that has the efficacy of research into falls prevention. I'm going the wrong way. So the framework itself, and unfortunately information being what it is, I can't just hand out copies of, but it's our framework itself is just a very simple flowchart. It's a one-pager, and this is what, these are the key components of this one-pager. The aim was to get consistency. Again, we had some sites that were managing falls reasonably well and others that were struggling a lot more. So we wanted to get that consistency across all of our sites. We wanted to make sure that our documentation was also consistent. that if I fell at one of my sites versus a different site, that the systems and processes were exactly the same. We wanted to make sure that no matter what happens from here on in, the next time one of these documents comes out, that we can quickly make changes to our documentation that will integrate best practice and really minimise that gap between, gee, we know this doesn't work very well, and gee, we can make a change to it. We wanted to make sure that the documentation was easy to access. Again, if it's in a file somewhere, people will not look at it. I shouldn't say will not, that's a generalisation. It's harder for them. They're less likely to look at the information for best practice. And we wanted something to be instantly recognisable as a document related to falls. So this falls framework, so our flow chart here, has 4 components to it down at the bottom, and they're really the important bits for staff to know about. One is around clinical governance. So we have to have a team that overviews what's engaged and what's involved in our falls prevention processes. There has to be ongoing education. As much as I said, education it's not proved to have an impact, it has to be part of what we do in trying to prevent falls. We need good assessments and intervention for our residents, and we need performance measurements and outcomes. We need to know what it is that is making a difference and what it is that is not. So it's important that all of those things are integrated to any falls framework should have something similar to those 4 components. They're the ones that were identified in the literature as being key. So quickly I want to tell you what sits under each of the components. Again, as much as I can't hand out what we've done, these are the overarching principles that I would really think would be part of a key framework for any organisation. So under our clinical governance, best practice. We need to know what it is, we need to make sure that our staff know what it is. It needs to be multidisciplinary. And again, I think in the residential aged care environment particularly, we've tended to have contract staff come in, particularly for your allied health, and I challenge whether that can actually work if they're not integrated into your falls prevention programs. You want a policy. You've got to have a policy. Nobody says you have to have it or you're in the NUA, so it's well worth doing. I would advise a falls focus committee, somebody, a group of people that come together every so often to review your organisational falls. There needs to be a process for how you manage a resident and a system after the fall. There need to be care recipient team meetings. And I know from an acute care sector, that just sounds ridiculous that there wouldn't be, but there are some facilities where the team don't sit down to talk about the care of the resident. If you don't have that, it's very, very hard to manage people that are falling frequently. And everybody needs to know what it is that they need to do. Here's the tools, and we'll go through some of these afterwards, but as a result of the review, these are the tools that we've ended up with as part of our framework. So we have a falls risk assessment tool. That's the one that's done to determine how at risk is this person of falling. We've got a falls risk management tool, and this was the new one for us, and I'll talk about that a little bit more after, but it embeds the best practice into a process. So it doesn't allow for that best practice to sit in a file somewhere, because someone has to look at it every time they review this client. There's a post-falls assessment. Again, I'll talk about that a little bit later. The bird balance scale, most of you physios will be comfortable with that, but we didn't have that as a standard item that we were doing as part of our physio assessment. It was just embedded within our physio assessment. We've now separated that out. Mobility assessment. There does need to be a system around clinical incident reporting. One of the big issues around falls is that when you start talking about falls, you will see your falls numbers go up. We are terrible at reporting falls, and it's only if we know that it's being investigated or it's being looked at more closely that people will fill out the forms. And I think one of the challenging things for the industry is that we often rate the performance of people like facility managers on the numbers. So if you've got lots of falls, there's a question around how well you're managing that facility. And I think, just as in acute care, the same thing I'm sure can happen. We have to be really careful about the way that we're measuring the performance of people in those pivotal roles, because the numbers usually only tell about this much of the story. There needs to be a clear referral process, and we, using iCare, have a separate falls domain in our care plan. So Some places will integrate falls throughout the document. We've chosen to keep it very much separate, but we no longer have separate OT and physio domains in our care plans. They are integrated into all of the other care domains. Just make sure that we integrate the interventions as well. Under education, I think something that we had really been overlooking to some extent was the resident and family information. ICWA have not been supported to develop a line of specific tools for residential aged care, and that's something that we're working to look at developing over time. And there's been some stuff that we can use, but it's not specific to the residential aged care environment. We need to keep doing staff falls education, and we need to use posters and falls prevention activities, and I'll talk about a couple of those before the end. And then the fourth domain is our performance measurements, those KPIs that we need to be looking at. So we do falls audits every quarter where we investigate not only the falls but also the documentation around the falls. So someone fell, did you fill out all the appropriate paperwork? Because if people aren't filling out the paperwork, our whole system falls on its head. So we need to make sure that that's happening. We've got some internal benchmarking between our sites, some external benchmarking, and again that's that company QPS that help us do that, so that we can look on the graph of 280 aged care facilities and figure out where we're sitting. We continue to collect our falls related data and we monitor that data. I just want to talk to you a little bit about the process, and again, sorry, I should have asked any questions about any of that so far. Okay. So if we go into the systems side of it, we did a pilot for 3 months, and certainly that was one of the most useful things that we could have done, because without it we wouldn't have ironed out lots of the problems that we had before we rolled it out to our 15 residential sites. So we chose 2 sites. We chose Bethanie Beachside, which is a 160-bed facility, a large facility, 4 distinct wings, some specific secure dementia environments, so really a good combination of the kinds of things you're going to find in residential aged care. And then we contrasted that with Kingsley, which is one of our smaller sites. It's predominantly intermediate care and it's only 37 beds. So a really different environment for the staff and for the residents. The key take-homes for us from that whole thing is the manager has to be on board. If the facility manager is not supportive of this, you may as well not go down the road, because the reality is that she was instrumental to making sure that these things happened. We needed to make sure that the iCare documents were created well in advance and that we had a chance to play with them before we rolled out the pilot. And then we took some time to really engage with the staff at site. So there were meetings with the CNCs, the multidisciplinary team, really everybody on the site to make sure that they were ready for this transition. And then throughout the trial we had both live, so we would go to the site and meet with the staff and get feedback about how things were going, but also constant email chatter about, I just filled out this document, not quite sure what this bit means, can you help me? And I think it really is important to have a key group of people who are prepared to respond to those kind of queries quickly, or else the reality is, you know, with any change, people just want to revert to doing it the way they did it before. In light of that, the other thing we did at the site was with the iCare documents, we actually got rid of the old system. So there was no old forms they could use. There was no choice in whether to adopt the new system. And I think that's important. So if you're looking, whether it be paper-based or electronic, if you're looking to integrate a new system, your pilot sites, you have to physically get rid of any old ways of doing things, because otherwise people will revert to that. So our results from the pilot, of course, it's really, really difficult to compare the rates, because we know that there's inconsistent reporting, that us having done some work around falls meant that our rates might have gone up. But what we did see was that there was a decrease in the number of falls at our smaller site and a consistent number of falls at our bigger site. But interestingly, we had less transfers from the site than we had the year before. Now, given in that 12 months our acuity had increased and our actual bed numbers had increased, we took that to mean that we were doing something right. We were certainly managing things better than we had before. Importantly, we also had really positive feedback from the staff. And I think, you know, feedback from staff comes and goes. Initially you put in something new and they say, oh, it's such a big system and it's so much more work and I don't have time to do it. So I think that relationship building with the team at site is really important to try and overcome some of those challenges. Probably the bit that's most interesting for me is what's in there. You know, what have we put into this system that makes it workable? And from a clinical perspective, that's certainly the key. So the first thing is it's far more multidisciplinary than it was before. You know, I think aged care, remembering that numbers of staff, care workers are our biggest number of staff at any site. And that historically, really, RNs have tended to be the people who have driven care at the site, supported by the care workers. So we've really engaged our physios much more in this process now. And I think by having the communication between the physios at different sites, it means that there's more sharing of information than historically. I'd be the one physio, I turned up at my one site, and I had to cope with whatever came through the door. By having the team developed across the sites, you can quickly email through or pick up the phone, hey, I've got this to deal with, I'm not sure what to do, can you help me? And I do think that team approach makes a difference. We've also developed a falls portfolio. So within my therapy team, so it's primarily OTs and physios that come under my supervision as direct employees, we've identified specific portfolios for them to hold as not so much the clinical expert, but the conduit of information. And one of those portfolios is held by a physio, and it is the falls portfolio. The care team meetings were the other critical part of team communication, that we spent some time looking at making sure that each of the sites had regular care team meetings and looked at a format around them to make sure that falls and the reflection on frequent fallers was part of the scenario, and that all of the team went. Within the care team meetings, frequent fallers. I remember very early on in this process going back to Emily and saying, what the heck is a frequent faller? How many, what's the number? What's the line in the sand? And there is no number. It's something that we have chosen to look at 4 falls a month, being that line in the sand, whereby the person goes onto a list for separate consideration outside the care team meeting. But the reality is that you need to figure out for your organisation, what does that mean? Who are those frequent fallers? In terms of under the clinical governance, the management after a fall has become a key component of this whole system. And this is where we've got our guidelines for different levels of staff around what do I do? Somebody's just fallen, what do I do? So we have these posters that sit on the walls of facilities. They're very clear, they're very quick, and they embed the best practice that we need people to follow for our policies. So it means that with the high level of agency staff within our environments, and that's tapering off, we're starting to see some retention from recruitment strategies, but there's always going to be an element of casual staffing within the aged care sector. This just means that it's very clear for people and that they can act on things much more quickly. So there's different versions of that. This one is the care worker one, but we have one for the RNs. We also have one specific to the southwest, where they don't have the same resources available to them. So we've just tailored them for the sites that they come from. And so then we've got the same for the RN-EN. And initially, there was some response from nursing staff particularly, well, I know what to do. I know how to manage my staff, my resident after a fall. And we talked about wanting to get consistency, that we didn't question the way that they were managing staff, but we needed to make sure from an organisational point of view that everybody was being managed the same way. So we had the flow chart through there. And we certainly considered interventions like the use of the prior team, the resources that were available to our sites in the development of these. The outlined roles and responsibilities, it is embedded in policy, who can do what, but we've also got the benefit of a program going on with the Health Workforce Australia, where we're trying to build a capability framework around our staff. And so for falls prevention, that has meant the development of some documentation that says if you're a level 3 care worker, this is what you are allowed to do after a fall. And we're looking to, I guess, support their use of their higher end scope of practice. I think sometimes we kind of dumb it down to the lowest common denominator at a site to make sure we're safe. But actually, we should be using our staff to the extent to which they're capable and competent to be used. So that's proving to be quite interesting. So this is an example of this here, where the care workforce has a document that says for assessment, problem solving, time management, care needs, care delivery, teamwork, how they can engage with residents and family, and what resources they can access. Really nice in terms of induction and early orientation to a site. Hey, I don't know what I'm allowed to do here, what am I not allowed to do, and these documents are helpful for that. Okay, we have a central admissions team at Bethany, which means that people have their assessments done before they come in our front doors, and that's lovely because it means that there can be some of the pressure off the team and off the resident to have to answer a myriad of questions when they've just walked in the door. A lot of that's done, and we can focus on settling our resident in and getting to know them a little bit better. So falls risk assessment has been done prior to admission, as has the person's mobility screen. Within our frats though, and certainly it's something that has been talked about in the past, frats are overdone. A falls risk assessment tool is exactly that. It's a risk assessment. It's not something that's going to guide your treatment and your intervention for that individual. And I think from an organisational perspective, a lot of organisations cover themselves by saying, well, we'll redo the frat every time the person falls. Well, let me tell you, if they were high last time, so frats generally will lead people to fall into either high, middle or low falls risk categories. Now there's some debate about whether that should be amended to just be high or low. What's the point of having a medium falls risk? For now we have one. But the reality is there's no point continually doing it. It's just going to tell you the person's still high risk. Oh yeah, they're still high risk. So we're doing all of this work and using this resource for something that doesn't actually guide our practice. So what we do now is everybody has a frat on admission, but post-fall, you only have a frat redone if you are medium or low risk. If somehow that might have moved you up into the next risk category. We also discovered that within our frat there were some inconsistencies with the way that we were scoring. And again, I think this is something from an industry point of view that's really, really useful to look at, is we pick up a tool, we look at it, we go, oh yeah, it's not bad, but I just need to tweak it a bit. I just need to make it appropriate for us to use. In doing so, we destroy any inherent validity and reliability that that tool previously had. And I guess one of the things that I'd really like to see happen in the future, and look, we've done that. In our frat, it hasn't been tested for validity or any of those things. We hope that by integrating best practice that we're moving in that direction. But we really do need to see some good, strong research around a falls risk assessment tool that's useful for the residential aged care sector. And then we need to hold that somewhere central, that any residential aged care facility can come in and go, oh yeah, we'll just use that one. It's there. It's simple, it's short. There was a couple of things presented at the conference that had 6 questions in them. If it's not short, it won't get used. So we need to look at that. The falls risk management tool is probably something that in acute care has been used for some time, and some recent surveys that ICWA have done are starting to indicate that perhaps they're being used more in residential care than we'd anticipated. But what it does is it asks a range of questions that come from here, from best practice. And so what it does is, I'll go into some of the questions in a minute. This fall has to be completed on admission. Again, there's no question. There's no one that cannot have one of these. So that's one of our audit questions that we look for. The series of questions embeds the best practice intervention. And then because we're electronic, we can decrease on the paperwork end of things by the answers to questions on this assessment form automatically populating the care plan. So it cuts down on that step of transcribing what's been assessed into what are we going to do. Anything that cuts down is a good thing. We need to review them, so that's in a change of status or every 6 months, and we review them post a fall to make sure that people are doing the right thing. So an example from the falls risk management tool is around mobility. So there's a question around the person's mobility, what their mobility screen has rated them as, and then it embeds the interventions that you go down and select. So what it means is it forces staff to go through a list of best practice interventions for that individual based around their assessment. And this was the gap between evidence-based and practice that we feel as though we've really shortened by having a tool like this. Again, it would be nice to just hand it out, and I guess I'd really like to see a situation where we can build on what we've done, and someone, you know, doing a doctoral study or something somewhere could look at developing a tool that we could hand out freely and be able to integrate its use. So the domains that are covered by that falls risk management tool are ADL and the person's skill sets in terms of caring for themselves, their vision, and not just, you know, do they have glasses, but if so, what sort? Are they bifocals? Now we know that bifocals significantly increase the risk for individuals. They're better off having bifocals are bad, multifocals are worse, better off having the separate sets of glasses. Continence. We know that continence and regular toileting are a big factor when it comes to falls. There's some evidence in the Cochrane review that toileting cycles work, but it's not strong enough to say that it's a definite link at this stage. Mobility and balance, the timing of falls, the when factor. What's somebody's nutrition like, their sleep patterns, their cognitive impairment and their medications. So they're the domains that get assessed on admission, and then if the person has a fall, to make sure that we're still doing the best that we can to prevent falls for that individual. Is there any questions about that? Does that sort of make sense? Yeah. Post-falls assessment, really logical. This takes away the guesswork around, what do I look for post-assessment? We've got two versions again. One is for the care workers and one's for the ENs, RNs. There are assessment forms that have to be filled out, so moves it from that file into the assessment form in front of them, looking at vital signs, conscious state, pain, movement, spin integrity, and then some system prompts. Okay, you've filled out this form, but have you done these other things that you need to do to manage the person's fall? Because as much as this seems complex, when you use it, it's actually pretty user-friendly. It just guides you through what you need to be doing to manage that fall. The clinical incident reporting, so the CRI system, we've changed so that rather than historically, if this form was completed, the facility manager knew, we've now got the physio being automatically notified of falls in the facility. But previously that really relied on an extra referral form being completed or somebody catching somebody in the corridor. Again, we want to take away that reliance on that system. As I said, we've still got the falls domain in the care plan, but because that's automatically populated by our assessments, it's much more reliable. Historically, what we had was sort of some very general comments that would turn up in the care plan because for most people that's what we needed to do. This is now personalised, so far more effective for our individuals. We've come up with the obligatory brochures and handouts. Again, we've done it Bethany specific, but we'd really like to see something that we could just have as best practice for all of residential aged care. And I would certainly see Stay on Your Feet and ICWA as the hub of excellence in falls prevention, and I would really like to see things sat there for all of us to access as we need to. The staff falls education sessions were interesting because there's certainly falls training at induction, but I don't know about any of you, if you've done any sort of formal induction recently, by about morning tea time it's all swimming up here, and I'm just not convinced that people take on board a lot of education on day 2, 3 o'clock in the afternoon. If that's where it's sitting on that particular format, I'm not sure people take it on board. We've made our falls training biannually, every 2 years, as a mandatory training, which historically it was not. So everybody had it at induction, but then not necessarily again. November is our Falls Aware Month. We've just randomly picked a month in the year. So we have Stay in Your Falls week. Towards the end of the year, we have April No Falls, where we focus more on our staff, and we've also got this 1 month that's just a Falls Blitz. We've got some toolbox sessions, and these are some photos taken from one of our recent toolbox sessions. Again, we're really trying to tap into what's most interesting for staff. How will they really engage? So we had our care workers walking in flippers. We had glasses that had been shaded out in different implements. Anything that we could do to help simulate what it would be like for somebody experiencing difficulty with their mobility. really hoping that that personal link would make a difference to the way that the person took on board the education. We're really looking to expand this. This was great as a pilot, but we'd like to grow that, and that's what we're hoping to do this year, is to expand upon the content of those sessions. We still do all the audits. You know, all of us have to do the number crunching, and so we've still got all of that going on. There's probably nothing in there that's sort of terribly different to what anybody else is doing. Thankfully, there's a red line and it's trending down, because I did feel as though in the midst of all of these false ambiguities around changes in reporting, around changes in systems, the fear is that your numbers go up. We're trending down. It's not hugely significant, but at least it's heading in the right direction. And I'm really just hoping that we can continue the conversations around falls within the residential aged care sector. I think historically people have been a little bit disconnected, and if we can bring that information together and really share our experiences, I'm hoping that we can get some best practice happening across the board. You know, at the moment we're looking at around about a 14% decrease in our falls over the last 12 months. That's significant for us. If we look at the falls and the distress that it causes for our residents, for their families, for our staff, and the costs associated with the falls, it's a significant difference. But the key is, you know, we need to maintain it. Certainly QPS came back to us saying that they're noticing a downward trend, and from the agency's perspective, that's a good thing. And we've managed to sort of tick off all of the boxes on what we set out to do from the framework. Still to do, annual RMRs, so the medication reviews are happening. I think we've got about 90% of our residents now, so we're still on the up and up for that. Vitamin D isn't consistently used across our sites, so we're looking at how do we promote that, and we've got some projects starting to happen with a couple of our pharmacies to look at how we grow that. Podiatry systems. Podiatry, I believe, has not played enough of a role in falls prevention, and has probably been seen as a contract service that comes in and provides a level of service, but not necessarily around falls. So looking at embedding that a little bit more. This policy has been designed to be integrated into our community care sector as well, so the framework will be used by our community care sector. That'll be within the next 12 months. Looking at trying to link to some of the universities. As I said before, we just need somebody with a passion for falls who wants to come in and do some research, so we want to find that. Pilot projects, the use of volunteers. Really interestingly, at the Brisbane conference, there was a discussion from an acute care site that had done a training program for their volunteers, and they would pair up a frequent faller with a volunteer during the period of time that their falls would spike. So if they're an afternoon faller, generally, they'd have the volunteer work alongside that person. And I think we tend to underutilise the skill set that our volunteers bring us, and certainly within the aged care sector, I think if we don't get on board and up the ante and use our volunteers better, we'll actually limit ourselves with the care that we can provide. And so they had 5 different sectors that the volunteers learned. Probably the 3 that I think are most logically applicable were orientation, where the volunteer would walk in, there was a sheet of paper on the wall of the person's bedroom, again remembering this is acute care, not residential care. Good morning, Mrs. So-and-so, it's such and such a time, gee, it's a lovely day, this is going on, so a bit of that orientation. While they're doing that, they're scoping the environment. They're looking for falls risks, they're looking at glasses, are they clean? They're looking at the floor to make sure that there's not stuff around, are the shoes done up, is the call bell within reach? All of those things that we know contribute to falls. So that was the orientation program. It's a nutrition program where the volunteer would come in, sit with the person while they were having lunch, not feed them, but prompt them if they needed it, move things around the plate, sort of have a role to play in that rather than just being present. And comfort care was the other thing. And I think that's something that a lot of our volunteers do with hand massages, talking to the person, just really having that connection with them. If that was happening during a period of high falls risk, what this organisation saw, I think, excuse my memory if I'm wrong, I think it was a 56% reduction in their falls. So it was huge. So I think if we could embed things like that, we might see a significant link. And we've also got some exercise physiology options through the EPC and looking at whether there might be some link between the falls and the use of increased exercise physiology. So there's loads of things that we can do. We continue to be involved with external organisations, and I think importantly looking to try and bring what we can do in residential aged care into the model of care for falls, and really seeing ourselves as part of that spectrum. And there is some research projects that we might be looking at in terms of exercise and sarcopenia. But there's also a program, and I've put Annie Holt's contact in here. She's looking for people. If anybody's got retirement villages, they're looking at a program around exercise and nutrition. So she was keen to have her contact details up there. So look, I wouldn't put us forward as being, you know, the person that's doing it all right, but I think we're trying, and we're trying to integrate the different components rather than just targeting one element of falls prevention. But I think what's really interesting is that within the room we've probably got a lot more collective information, so I'd just be interested in anything that you might be doing or any questions you might have around our process in terms of falls prevention. Any questions or any comments?
I was going to ask about vitamin D. Is that purely looked at from a medication, like the pharmacology point of view, so nothing, no sun exposure, no...
I mean, certainly sun exposure can have a good effect, but from the evidence, it would appear that if somebody's got a vitamin D deficit, it's not going to be managed by purely sun exposure. But I think we can do better. I think looking at activities can certainly make a difference, but if somebody has got a defined deficit, it needs to be treated. And that's where that management and that monitoring of bloods, I think, becomes critical too, because that's the other risk, is that we put somebody on something and it continues.
With the vitamin D, did you think it related to falls or the outcome of falls? It's more to do with...
No, it has both the risk of injury and the risk of falling. Both are affected by vitamin D. Yeah, which was, you know, you would think that it would be the impact on bone structure and the likelihood of an incident.
It also affects muscle strength, doesn't it? So
I think so. I'm certainly, again, no vitamin D expert, but it's all in the evidence. And I know Nick Waldron has done lots of research around it, and it's certainly the one intervention that he would recommend.
Just to comment, I'm not experienced in aged care physio by any means, but just in the half year that I've been working there, I find when there's a fall, I turn up, you know, for work on the Monday or whatever, and I feel like all that's happened is they've referred to the physio.
Yeah.
So like they might have fallen 6 days before, and I feel like it's sort of just dumped on me, like, oh, fix it. Like, they've fallen. Like, what are you going to do about it?
And I think
and they might have a list of past medical history and lots of things that we're never going to change.
Yeah.
But it's, as you sort of feel that the weight of it, the stress of it on you, and I'm not saying that's global, but if there's a plan that where, you know, there's more of a system and more of a spread of responsibility, I think that can be a good thing.
And I think there's two parts to that. One is, I guess, having something like a falls risk management tool where people are forced to think through the evidence is a good thing.
Yeah.
But the reality is, physios are probably not going to change from being on site once a week. It'd be great to say there's enough money in aged care that we can have physios full-time everywhere, but we're not. So we have to somehow support that system in some other way.
Yeah.
It's a huge challenge. Huge challenge.
it's interesting that, because I've worked with Miriam, and we actually been using the falls risk management tool for quite a while now, 9 months or something.
Yeah.
So it's interesting that, but we haven't got any audits in place, which is something we're looking at the moment.
Yeah.
It'll be interesting to see whether Miriam's like whether they're actually using it at all.
And certainly,
I think
the
that
process.
I've certainly found there's big confusion between, are we doing frat or fruit? Which one should we be doing both? So maybe that's
We actually got rid of the frat altogether.
did you?
Because we did this sort of in consultation with Annette Hill, based on the fact that essentially everyone who comes into residential aged care is a falls risk. So going through that process didn't really give us any additional information when we had to go through those falls prevention strategies anyway.
Yeah.
So we just go straight to the management.
I think the hard thing, and I alluded to it before, is often our residential aged care is driven by accreditation, and there are still auditors that will come in looking for that. So I by no means am saying that that's why we should do things, but I guess if we make a decision not to, then we need to be really sure that our staff are comfortable with knowing what that person's risk is and that we're responding to it appropriately, because that's where it starts to get very, very difficult, I think.
I think, yeah, I mean, just an example from this morning, and maybe it's just fresh, because it was this morning, but one of the nursing staff said, oh, can you see Mr. Smith, you know, he doesn't want to use the frame. I said, and he never has walked with the frame before. Oh, well, why? Oh, well, he was really dizzy and he just didn't want to use the frame, he got really grumpy at me. And there'd been no process of, like, anything, anything at all, of why, okay, well, why was he unsteady? What were his symptoms? What tests did you do? Oh, well, I took his blood pressure, but there wasn't much of a drop. There was a 20 millimeters mercury systolic drop, which is significant. Which is significant.
Yeah, we'd all
and that was from sitting to standing, not even lying to standing. So the measure hadn't even been done correctly. You measure it from lying to sitting or lying to standing. Yeah. And then, oh, well, what are his meds? Is he on antihypertensives? Have we looked at going to the GP to reduce the dose? Oh, no idea what his meds are. There'd been nothing. And it's just like dumped to me, like, oh, tell him he needs to use the frame. He'll listen to you, the physio. But there'd been no process.
And look, I think, unfortunately, that is the reality of aged care. And you know, we hope with time that will change. But in the meantime,
we're left. If you give it the tool to follow it, at least it's as easy as possible. Yeah.
But I do think, picking up on Amanda's comment, unless you're auditing it, guaranteed there'll be forms not done. You know, we audit, and they know we're auditing, and there's still some forms that are not done. But with time, we're hoping that regular audit will mean that we can target our feedback to those individuals who might not be completing things, and actually make a difference that way.
Because I wasn't saying anything was rocket science.
No.
It was just it was standard things that I assumed had been done properly, that hadn't been even thought of. And if they're on a form or that sort of prompts, you know, and whoever comes across the faller, then when I turn up 5 days later, then maybe I've got some good evidence to go off for.
Absolutely, and certainly with our falls risk management tool, and you may well have done the same, we've sort of got the question, and then we've got some statements around the common things that affect falls, and then you can select your intervention. So it's kind of a 3-stage for all of the key factors that we know relate to falls to really help prompt people in thinking about those things. But look, and with the turnover of staff that we have, the more that can be embedded in there, the better.
Sorry guys, this is Pranjit from Cato Meetings. I will have to leave the session as it's over time now for me. But thanks anyways for Emily and Felicity. I really enjoyed that, and hopefully we will be able to incorporate something out of this into our practice.
Great, thank you.
Thanks, bye-bye.
Anything else? Any other queries or comments?
Just a question around spoken of dementia mapping.
Yes.
Where can we find out more about it?
Atlantic Therapy Services are running some programs in dementia mapping. And look, again, certainly not an area that I'm any expert in, but it's really around mapping the individual, what's going on for them, how it is that their dementia presents, and then giving some strategies around linking our interventions to that individual. I think, again, we're using general approaches to try and manage behaviours of concern, and that's a far more specific way of doing it. So yeah, Atlantic, I think, have still got some courses running on that.
Unfortunately, it's today, tomorrow, or Wednesday.
Oh, of course it is.
They don't know when the next slot will be.
Okay, but I guess the more of us that are saying, hey, I really want to do this,
yeah.
the more likely they are to run them again. And I don't know if Alzheimer's may also have some information on dementia mapping, but it'd be well worth contacting them also. Well, thank you very much. Obviously, you'll have my contact details through Emily. If there's any other questions that I can answer, I'd be more than happy to. But yeah, thank you very much for your time.